I'm Nate Parker. I'm one of the intensivists here on staff. Today we're going to talk a little bit about advanced mechanical ventilation, or at least part of that. So, like I said, the first suggestion was to talk a little bit about the rationale for low tidal volume ventilation in ARDS and why that's important, and why sort of the theoretics behind it, and then some of the data behind it. Would that be helpful to folks? Mm-hmm. The other thing we could potentially talk about would be sort of thinking about sort of how to troubleshoot things on the ventilator and what you see, and what to think about sort of, you know, what sort of might tip you off that somebody's sort of having some kind of a problem, or how to sort of assess the problem a little bit. Do you guys have a preference either way?
The hard part.
Okay, so we can talk about that to start with. So the first thing about ARDS is kind of what is it? So ARDS stands for, anyway.
Respiratory distress.
Yeah, acute respiratory distress syndrome. The definition of this, this has sort of been revised over the years, but the most recent definition includes a couple of things. Any thoughts?
Oh.
No,
Inciting event.
so the first one is in the acute, right? So it's acute. So it has to, you know, relatively short onset. So acute onset of, you know, development of syndrome. So I think it would be within a week of the reported insult, I think is off the top of my head what it's supposed to be. The next one is that you have to have some amount of respiratory distress. You have to be hypoxic, and that's defined as what's called the P to F ratio, less than 300. So this is the PaO2 divided by the FiO2. So for example, if your PaO2 is 100, but your FiO2 is 100% or 1, then your FiO2 is 100. And so this gets graded out into 3 different categories. So 200 to 300 is mild, 100 to 200 is moderate, and then less than 100 is severe. You'll see less than 150 being characterized as severe in some places, but that's one of them. The other thing you have to have bilateral infiltrates. So on a chest X-ray, you have to have disease in both lungs. And the other thing that you need, this used to be a requirement that you would have a swan and you'd have a wedge pressure less than a certain level, but you were trying to make sure that this isn't heart failure, essentially. And so that it used to be that the definition included like swan numbers, but since we don't do that anymore, this is just basically just reasonable exclusion of heart failure as a cause. And so this can be due to a number of different things or a number of different insults. The most common one is just pneumonia, sort of a pulmonary insult, right? But there are a number of other causes of ARDS. Does anybody have any other off the top of their head? Kind of related to this would be aspiration. There are a number of sort of non-pulmonary.
Sorry? Pulmonary contusion?
Contusion sort of, but and even just trauma in general. It doesn't even have to be chest trauma, just being sick from trauma. So, and then other classic ones are pancreatitis, non-pulmonary sepsis. And this is just, you get sort of systemic inflammation in the body, and it affects the lung. You get lung dysfunction as a result of those things. So when you're thinking about, something happening acute within, a week or so of one of these illnesses, that's considered the definition. And basically what happens is you just get diffuse damage of the alveolar membrane, and they get flooded with proteinaceous fluid, and you have trouble ventilating them. So part of the insult of ARDS is that what you end up with is a lot of alveoli that are just filled with fluid, and the lungs get very stiff. So the thinking used to be that you just try to get as much oxygen as you could in these people, and the mortality rates were very high. What we found out is that using an approach where we try to avoid doing damage to the lung with the ventilator actually ended up with better outcomes. So what we really try to do with ARDS is, we're looking at, there's a couple of different ways that ventilating these people causes further damage to the lung. So you can get, it's called barotrauma, where the alveoli are kind of overdistended. They get kind of stretched and it leads to sort of worsening injury, that causes the lung to get inflamed and to actually sort of perpetuate the ARDS. It can also lead to things like pneumothorax and trouble like that. The other side of the injury related to the ventilator with ARDS is something called what's called atomic trauma or shear force. So while you have some alveoli that are kind of overdistended and open, you also worry about some alveoli that are sort of full and stuck shut and sort of pop open and closed when you're ventilating them, and that kind of shear force that's also damaging the lung. So when you think about the lung in general, this is, if you look at sort of this is actually, so pressure. So when we're ventilating these people, as the pressure goes up, the volume of the lung should go up, but it goes up in a certain way, and you can think about it like this. So at low pressures, you can increase the amount of pressure, but the lung doesn't really, the volume doesn't change much, and you're not recruiting the lung yet. Until you get to a certain point in which you start to, so the alveoli here are just sort of atelectatic and full of fluid and aren't open. As you start to increase the pressure, you get this sort of linear relationship where the higher your pressure, the bigger the volume of the lung, and the more alveoli you're recruiting. And then you get to a point again where they start to become overstretched, where again, as you increase the pressure, you don't get any more volume from it, and it's because these alveoli are just kind of overstretched. And so the basic idea, the kind of theory behind both low tidal volume ventilation, so limiting how much stretch you have, and then the use of relatively high amounts of PEEP, is that you want to ventilate people on this part of the curve, where you're getting alveoli that are not overdistended, so you're using relatively low tidal volumes, but you're sort of keeping open the PEEP from the back end. And so that's at least the theoretical idea behind why we tend to use more PEEP and less volume. How do we assess that we're doing a good job? What does this mean at the bedside of what we do and what we're doing? So the sort of landmark study that came out looking at this kind of in the early 2000s compared a tidal volume, so this, sort of the original ArthNet study, so low tidal volume ventilation. So a tidal volume of 4 to 6 cc's per kilogram of ideal body weight. And this is basically based on height and gender. So if you have a big, large person, it doesn't mean kind of watch that compared to I think 10 or something like that. And they targeted what's called a plateau pressure of less than 30. And using this kind of a strategy, there's a significant improvement in mortality in folks with ARDS. And so when you run into somebody like this, it's worth, and it can be, it's something that's easy to overlook. And there's actually some observational studies that came out relatively recently showing that ARDS is sort of underdiagnosed and overlooked quite a bit, and that people often don't receive low tidal volume ventilation. It's something that kind of happens. So it's worth sort of thinking about, when you have someone who's sort of moderate to severe hypoxic, is needing support from the ventilator, has one of these issues, and this is, almost everybody, right? Is their tidal volume appropriate? Are we hitting the targets that we should? And so that's sort of the basis for when we're thinking about ARDS, how we manage these folks, and that's sort of the backbone of the ventilator management. So making sure that the tidal volumes are appropriate and then following the plateau pressures. Does everybody understand what a plateau pressure is? So we're talking about that? No? Okay. This is another good, I think. We can talk a little bit about this, and maybe just spend a couple minutes on troubleshooting things. So plateau pressure. So just when we're looking at things, so most of the folks that we ventilate down here, almost all of them are exclusively in a mode that's called volume control. We also call it AC. And so what the ventilator does is it delivers a set tidal volume. So if this is, let's see, this will be pressure, this is flow. So the ventilator delivers a set tidal volume with any given breath. So the flow tends to look kind of like this. Pressure waveform kind of looks like that. And so the ventilator sets the tidal volume. The pressure that comes out of that, the pressure that's required to deliver that breath, is determined basically by the size of the breath and the lung mechanics, like how stiff the lung is. There are two components to the pressure. One of them is the peak pressure, which you can see in the ventilator all the time, and that's the top up here. That's just when the pressure gets to the top. That's the amount of pressure required to deliver that volume, to distend the lung, and also to overcome the resistance of the airways. Those two things together. Because there's that component of airway resistance in there, we don't really know. It's kind of hard to know how much of that component is airway resistance and how much is really being seen by the alveoli. It's really the distending pressure of the lung. And so the way that we overcome that is to use what's called plateau pressure. So basically what we do is we have the ventilator deliver the breath and then hold it, so there's no flow, so we don't have to worry about overcoming the resistance of the airways. And then you get this little tail on the pressure waveform, and you can see it'll drop, so that it comes down from the peak, and that's what we call it a plateau, so it just holds. And because there's no flow here, like I said, this is the pressure that's required to hold the lung open at that particular volume, and so that's what we measure. And so this is strictly required. It's strictly measuring just like I said, how stiff the lung is, how much pressure we're exerting on the alveoli themselves, and the rest of the chest wall and that kind of thing as well. So that's what we're measuring there. Does that make sense? Yeah. A couple more minutes. Thinking about sort of troubleshooting things. If you have somebody who's having trouble with the ventilator, if they're becoming more hypoxic, or if you're having trouble with pressure limiting or that kind of thing, one of the things is you can actually use the plateau pressure or the peak pressure to help kind of try to differentiate what might be happening. And that difference between the peak and the plateau pressure is sometimes useful. Basically what this tells you, if you look at the difference between the peak and the plateau, that basically gives you the component of how much of that pressure is due to the resistance in either the airways themselves or even in the endotracheal tube. So if you got somebody who's decompensating, doing worse, and you notice that the plateau pressure, that this difference is quite large, so it looks kind of like this. You have a normal plateau pressure but a high peak pressure, that would make you worry about this some sort of problem with either the airways or in the endotracheal tube and obstruction of flow. So this is airways disease, so asthma, COPD, bronchospasm, mucus plugging. I've actually seen endotracheal tubes that get sort of obstructed or kinked or sort of plugged up with mucus, that kind of thing. And so that's something to look out for. If you, on the other hand, have something look like this, where the people are pressure limiting and you have a high plateau pressure, that makes you worry about other things in the lung or the chest wall or in the respiratory system that is causing increased pressure. And so this is things like, worsening infiltrate or pneumonia, pneumothorax, abdominal compartment syndrome. If you're resuscitating somebody, your belly's become very distended and that kind of thing. So this can be sort of helpful as well when you're trying to think through why somebody is pressure limiting or not doing well. Does anyone have any sort of questions about troubleshooting ventilator things you've seen that you want to know how to deal with, that kind of thing? One of the other things we could talk about real quickly would be how to deal with refractory hypoxia, because it kind of ties into the ARDS talk. So, tools at your disposal for people who have refractory hypoxia, and we usually think about it in the setting of ARDS, so that's not always the case. using this low tidal volume strategy actually you tend to have worse oxygenation than you do with a higher tidal volume strategy. And the basic idea behind that is the two things that drive oxygen across the lung are the FiO2 and the mean airway pressure. And so if you're trying to limit the pressures, then your mean airway pressure is going to be lower, and your driving pressure or oxygen is lower, and your oxygenation ends up being lower. So there are other things that you can try to do to help improve your oxygenation. And when you can't get that done, we use normal strategies, and the nice thing about all those is they tend to start with P. So for refractory hypoxia, the first one we think about is relatively easy, and that's increasing the PEEP. What this does is a couple of things. One is it helps recruit alveoli. So, talking about having alveoli on the bottom down here that are not recruited or not open, the higher you increase the PEEP, the more alveoli you recruit, and you're able to kind of get better VQ matching. The other thing that it does, independent of that, is it also increases the mean airway pressure. Because if you have a PEEP and a plateau pressure, or peak pressure, you're kind of cycling back and forth through this between the respiratory cycle. If your mean is somewhere in here, if you increase the PEEP, then your mean just becomes higher. So you get a higher mean airway pressure out of that. So someone's hypoxic, you can think about increasing the PEEP. The other thing that we think about is proning. The other thing that starts with P. So, and this one is one of the interventions that has been shown, at least in one instance, to have a mortality benefit in ARDS. So, just real quick, for people who have a P to F ratio of less than 150, have ARDS, and have I think a PEEP requirement of, I want to say it's 10 and an FiO2 of 60, although I don't know if that's totally right off the top of my head. This is something that's been shown to improve mortality outcomes in ARDS. And the reason for this is not, is why this works or why this helps is not abundant. It's not like totally clear, but there's some thought about it. There's redistribution of blood flow in the lung when you're on your stomach, which is kind of hand wavy. Or the other thought is that it just kind of gets the heart off the lower lobe, the left lower lobe, and you get sort of better. You're just sort of getting more tissue to ventilate. The other thing we think about is paralyzing people, so paralysis. This is another thing that's been shown in folks with relatively severe ARDS, and again, it's a P to F ratio of less than 150. And the reason being is this, the main way that this works, we think, is just by improving synchrony. So you're not kind of fighting against the ventilator. The pressures are getting lower. Recruitment is better, that kind of thing. You're also using less energy, moving around, less oxygen being used, and so that we think that helps in some way. So these two things definitely have a mortality benefit. The next thing that we sometimes think about using for refractory hypoxia does not. It's been shown to improve oxygenation, but not mortality, and that's inhaled prostacyclins or inhaled nitric oxide. And these we think about using these in pulmonary hypertension, but they're useful in bad ARDS and refractory hypoxemia, because what they do is when you deliver them to the lung, the ARDS is kind of patchy and it's not distributed evenly. And so there are some lung units that are better ventilated. And if you breathe in something, the inhaled nitric oxide or whatever you're using gets to the lung units that are better ventilated, so they get more blood flow. So the VQ matching gets better. So you get more blood flow to better ventilated units, less blood flow to bad ventilated units, and better oxygenation as a result of that. So that's not. So this is something we don't pull out very often, but something we do have available is inhaled nitric oxide, and in people who are very hypoxic, it's certainly something we can do. The other thing we think about is just making sure that if there's any pleural space disease, that it's taken care of. If there's a large effusion or something like that, you should make sure that it's drained. What else am I not thinking about? It's also improved sort of recruitment maneuvers, which we can talk about a little bit. The other thing is peeing or diuresis. So you have to start to work to get them all to start with pee. But there's there's at least one study showing that if you keep people on the dry side, they tend to oxygenate a little bit better, and certainly the dry lungs are heck along. So for people who are ARDS, even if they don't look volume overloaded, once they're out of their shock phase, we tend to try to diurese them, and that seems to help to some degree. I think that's most of them. And the other thing is also just recognizing these people are often quite ill, and the mortality rates and severity rates can be quite high. So this is something to think about in terms of just what your goals are. The last one I don't have a P for, and it's not something we do here, but it's a rescue strategy. There's always consideration of transfer for ECMO, but I've yet to have to do that here. How's that?
With these steps, would you just do one after the
Yeah, I
other?
don't think these aren't necessarily in any
case
given
to
order.
case?
Yeah, they're not in any given order, but I think if you were thinking about steps for these things, what I would think about probably, I would think about this first. You know, this is sort of variable. Like if they're not in like fluoride septic shock, you can diurese them. If they are, you can't. The general progression in my mind kind of goes sort of, you know, you bring their PEEP up, you make sure that they're synchronous and well sedated. If they're not, you paralyze them. If you're still having a problem, you know, Crohn's in there somewhere. And in some ways they all come together. And we probably should be proning more people than we do. You know, there's sort of a good literature to support a benefit in folks with moderate severe ARDS. That said, you need to have like a run-in period, so it's okay to sort of try to get them. Because a lot of people will stabilize out after the first 6 to 8 hours, so they come in, they look like they have pretty severe ARDS, you get a chance to settle down, get recruited, and then so it sort of calms down. But so definitely, you know, PEEP, deep sedation if they're still asynchronous or still quite hypoxic, paralyze them, Crohn's. But this is sort of something I pull out as kind of a last resort because it doesn't really tend to have it's not much going to have a mortality benefit. This is sort of a case-by-case kind of thing. Like I said, this is something that you do if you have room. There's actually just a study that came out like this week that I haven't sort of, I only read the abstract to be totally upfront about that, but looking at this as sort of an early strategy for folks with very severe ARDS, like pediatric shows less than 50 or 75 or something. There's a couple of different inclusion criteria. Trying to see if you randomize them to ECMO up front, if you do better, and they weren't able to show a statistically significant difference, so there was like a lot of crossover, and mortality rates were pretty high. So this is also like
attention please. Inpatient, code stroke, adult, VA wing,
so
second floor, endoscopy department.
That's kind of a brief,
Freon.
but helpful.
Attention please. Inpatient, code stroke, adult, B wing,
Cool.
second floor, endoscopy department.
Questions
Freon.
about any of that? No? Okay. All right.
Thank
Thanks, guys.
you.
Yep.
Thank you. Thank you very much.